I would like to apologize for technical problems. I think we'll continue. We'll take it from Sister Mbata. Sister Mbata had a comment. I don't know if it was a comment or a question. I will again give this opportunity to your sister. Who does not see me? Do you hear us, guys? Do you hear us?
Yes, I can hear you.
We can hear you.
Okay, Sister Mbata, are you still there?
Oh, yes, thank you. I was asking, I was saying that thanks so much for the presentation. I've gained a lot, and my comments or questions, I think I was left behind regarding the Umyeni herb. I don't know it, but I don't know. I've seen that. How is it prepared? And my question is: is it ingested, or how to use it after the preparation? Should I have to apply it, or to drink it, or use to massage where there's a pain in that area? That's why I was left behind. Thank you.
Thank you, Sister.
Okay, the only I said you use half a glass of boiling water and then you add the umnei bark and then you ingest the water. You let it sit for a few minutes and then you drink the water. You can also just eat the bark as it is. It does not really cause any side effects.
Okay, thank you, Teta. Sister Mbata, I think you got that response from our presenter.
Thanks so much for the response.
Okay, there is a comment on our chat box. I'll read it as it is from Tandas Melane. She says, thank you so much for the presentation. I'm actually shocked garlic is discouraged, but what would be your comment about the use of the white salt stem cell chlorophyll, moringa, and other supplements, herbs, or it could be discussed. It could be discussion for another day.
Okay. For now, I can only comment on moringa powder because I've had experience with it and I've heard good reviews so far. So moringa is also used. It actually helps to even boost the immune system. It's just that I couldn't find any evidence on the type of pain it helps control. That's why I didn't involve it. The other names, well, I can't comment on those yet because I also have to do some more research on them myself.
Okay, thank you so much, Sisi. I think Sister Zilede, you got the response. Would like to continue if there is other comment or a question from the floor. I will still take this opportunity. Going twice. Okay, I see a hand from Margaret Dameni.
Thank you very much, Jobe, for an enlightening lecture. I would like to maybe to add or maybe to comment on umhlonyane. Is it really working? Especially, we got to know about it during the COVID season, and many people were using it, and they were saying it is helping in their flu. It relieves the flu symptoms. Can we also encourage it to be used? Thank you.
Okay. Umhlonyane, well, mostly it is used for relieving those COVID-19 symptoms. I've also heard about it. But my problem, the reason I didn't involve it was because we were focusing on pain management. So I don't know really the part of the pain where it helps with pain. I've also had patients who have commented on it saying that they are using it for pain, it helps somehow. But I can't really attest to that because I don't know the type of pains it works on. Otherwise, for the flu symptoms, yes, it is recommended to use. Other people still use it, and some actually use it to compress somewhere. So for now, that is all I can say on umhlonyane.
Okay, thank you so much, Daisy. I'll go back to Mingmare Dlamini. Dlamini, to hear the comment.
Thank you very much for the response. I don't think it's a comment, but maybe it's an addition. It may help in the relief of joint pain, because most of the time people with flu, they have joint pains. So if using the umhlonyane, sometimes it helps in relieving joint pains. Thank you.
Thank you so much, Mage. The interest of time, if there is no comment, we will move on to our today's case presentation. From the hub, our case presenter today will be from Eswatini, based on war origin. I will give this opportunity to look at this. I think she's ready.
Yes. Thank you, Mr. Kele. Can I just give, before presenting, can I just give a short update about our last case presentation? If you can remember, we had a 43-year-old breast cancer client who didn't like taking any Western medication. So yet the level of pain she was in was increasing by the day. So as you advised colleagues, we've been having many counseling sessions with her, trying, or initially she was scared to take the Western medication because she was fearing that she would be addicted to it. So as you advised colleagues, we've been trying to explain bit by bit how the narcotics will not cause her to be addicted again if it's taken the right dose for the right amount of pain. So I can safely say we are having mini progress on it. As now she is able to ask questions like, how will I say that now I am addicted? What must I do immediately? I realize that I am now addicted to these opioids. So can we continue then to today's case? The presenter is Eswatini, as introduced. So our client today also has breast cancer. She is 45 years of age and she is a female. She is a new case. Sorry about the follow-up there. The main problem with our client is that she has so many social issues and misguided beliefs about chemotherapy, which have resulted in her refusing chemotherapy. So our main concern is that when chemotherapy is delayed, the cancer cells may grow and spread to other body regions, resulting in worsening of the cancer. So the client's chief complaint was severe pain on the breast, which results in her being unable to go to work. And also that the client had to leave her home area and rent a house elsewhere due to sibling rivalry and disputes. The client has five children whom their father passed on. She takes care of them without any assistance from anyone, and most times she cannot even afford their basic needs. The client has anxiety on what will happen to her the day she is bedridden, because both her parents are bedridden. So she has the worry that then who will be able to take care of her children. On assessment, physical assessment, her general health status is normal, but on examination, her right breast is dimpled and shrunken in appearance. There are spots which appear swollen and reddish. The breast is painful, especially on touch, which sometimes hinders her mobility of the dominant hand and arm, which is the right hand and arm. Her skin looked pale, but she is well hydrated. So emotionally, the client is very emotionally unstable. She was in tears almost the entire time the hospice team was there with her, whilst she was narrating her social problems. The client has emotional pain mostly due to the fact that she has thoughts on what will happen to her children's welfare the day she is bedridden and can no longer be able to put food on the table. Socially, she's having too many problems too, as her elder son reported that the house he is living in is falling apart. The elder son is currently in high school, so he was also not able to be enrolled on the government office list because the head teacher refused to give the letter in time. Well, first the head teacher said before he can give them the letter for applying for government office list, he said they must be able to pay 3.5 to the school first. So the process of loan application and everything took time. And then when the letter was there, the head teacher was not able to communicate in time to the client that she can now come and take the letter to the DPM's office. So now the son has missed out on this opportunity. But the client said she has been going there every now and again, every time when she gets a chance to the DPM's offices. So they say they will enroll the son, but for next year, not for this current year. So our client doesn't have family support. She has family support from both her parents emotionally, but she also fears burdening them with her problems as they are also sick and bedridden at home. Her siblings also do not assist much in terms of caring for her parents. She sometimes has to skip work in order to go and tend to her parents, like doing washing, cleaning, and cooking for them. So spiritually, the client's belief system is deemed positive for her health as she verbalized that she's a Christian and is able to continue doing the activities that strengthen her belief and bring her closer to God. But her church isn't that much supportive. So our client did say that she thinks it's because she's quite new to the church. So on medical history, the client is a known Ayurvedic client on art since 2013. She has breast cancer on the right breast. So the client did say with the history of the breast cancer that she was vaccinated twice. The first dose was Johnson & Johnson, and then the second dose was AstraZeneca. So the client reported that immediately after the first vaccination, she had right arm pain, which was radiating through the whole arm. The following day, she couldn't move her arm at all, so she went to the clinic and was given paracetamol and vitamin B complex. She says she felt better, and then she got vaccinated for the second time. She had the same pains again. She was given the same medication again, but this time the pain didn't subside. She also then noticed changes in her breast shape and felt a lump that wasn't there before. She then went to hospital where after several investigations, she was diagnosed with right breast cancer, but the client has opted out of chemo. So she said she did consult. When I asked her, she said if they had explained to her about chemotherapy, she said they did, but she's seen many of people she knows who had chemo and who also had the mastectomy, the removal of the breast. They didn't survive for long. They died thereafter. So that's why she's scared to do the chemo or any other procedure which will help towards the cancer treatment, because now she fears leaving her children behind. So the relevant past medications are both the COVID vaccinations, the first and the second dose, So currently she is taking her heart medications, which is tenofovir, lamivudine, and dolutegravir. She's also on paracetamol 1 gram. PO. I wrote the OD because the client said she only takes the medication when there is pain. And then she's also taking the supplements, ferrous sulfate and folic acid. So on the pain assessment, the client said she's had this pain for 6 months now, which is stabbing. She said it comes and goes. So sometimes it just comes unexpectedly. She rated it at 5 out of 10, and that it is intermittent and it is usually precipitated by physical activity, and it's relieved by medication and rest. It does affect sleep, but it doesn't affect mobility. So when she has taken this 1 dose of paracetamol, the 1 gram, she has total control of the pain so far. So I'll skip this since it's the same. So we've had only 1 session with our client, which was on the 6th of this month, which is Monday. So we are yet to review her after 2 weeks, which would be the 19th of June, 2023. So the social history, the client is employed and she is a packager in some firm around Babane. She said she stopped schooling in Form 5. So with the social economic class, we rated her at low. The client is widowed. She has no history of any harmful substance abuse. With the relevant conditions with the family members, both parents have hypertension, but the father also has diabetes. So with the advanced directives, advanced care planning, we didn't do it yet since our visit was mostly just an initial assessment. So maybe with oncoming visits, we'll be able to do that. But what we noted after assessing her mental status is that as much as she's well-oriented to all spheres, the client is emotionally unstable due to several issues and the way the cancer started, because she said even her current boyfriend told her to not go for the vaccination, but because everyone was going, and also she thought that since she's HIV positive, it would be best for her to vaccinate for COVID. So yet she's also saying that she's seeing it on news and social media that most people are having COVID, are having cancer after being vaccinated for COVID. So that makes her very emotional when she relays that. She cries tears. So her vital signs were all normal. We couldn't do the SpO2 since we don't have the oximeter. And her pain score was rated at 5 out of 10. Her functionality score is at 1 because she's still able to do some activities like going to work. So her main symptoms are pain, which is moderate, anxiety, which we rated as severe since she's very much anxious about her children. And also, well, the depression, we couldn't rate it that much, but seeing as she was crying and everything, we just said we rated at moderate. We couldn't do any focused lab investigations. So with the further plan of care for the client, it includes what we actually did even on the visit, but it will be what we continue to do as we visit her. So physically, we will fully explain to the client about chemotherapy, its advantages and disadvantages, so that the client can be able to make an informed decision and to also clear any existing myths about chemo. And we also continually assess and manage any physical pain the client has. And we'll also continue with health education on general health promotion measures. So luckily, we visited the client with our nutritionist, who was able to educate the client about the proper nutrition, proper diet she can be able to take with the little money that she has. And we also educate the client on non-pharmacological pain control techniques. So emotionally, we are going to allow the client to release all her pent-up emotions whenever she has a counseling session with the EHA team. We also assist the client to recognize and reinforce possible positive coping strategies she might have, and also to encourage her to verbalize her thoughts and feelings on the whole illness journey. Socially, we'll reinforce the current social system the client already has, which is her boyfriend and her parents for now. And then we also provide support socially to the client by also referring her to our social worker at hospice at home. Well, she did say she was seeing another social worker in Mbabane government, who was able to assist her through her journey, but unfortunately, the job contract for that social worker was not renewed. So now there's no one in that office. So her sessions have stopped. But we are very positive that since we also have our very own social worker, should be able to continue assisting the client. And spiritually, we do continuous assessment of the client's sources of strength, hope, meaning, peace, love, and connection. And then we'll further explore the relationship between her spiritual beliefs and her health. And then we'll strengthen those current spiritual activities which are positive for the client's health. So that is our case for today, colleagues. Mainly, we would like to have your input on how would you approach with assisting with such a case, especially since our main concern is that the client is refusing chemotherapy. Well, we would like to respect the client's wishes on refusing the chemo, but we want to be sure that she's refusing the chemo after having all the information about chemotherapy, after having the meds cleared, so that she makes a proper informed decision. So thank you, colleagues. That is our case for today.
Thank you so much, Tani, for informative presentation. That's the case for today, colleagues. And we have this client, as she stated, our problem that the client is refusing chemotherapy. The good part is that the client is on stage 1 according to functionality status. So any therapy can be possible. So how can we help this patient, colleagues? I will give this opportunity to the floor. If there is a comment, question, we'll give this opportunity. I can see a hand from Pumelelo. Can you say something, Maritami?
Thank you very much, team. It is really a learning curve. We are learning. And I'm so happy that even our cases, they go hand in hand with the lesson of that day. With this one, even the parents have non-communicable disease like hypertension and diabetes, which also means that they also need to be involved in the care. They also need to get some supplements. I wish we could also know the age differences for the children, for her children, the ones that she said she has, and she is the sole breadwinner for. Yeah, that is all I think I have. It's just a suggestion that we add. We also include the parents in the care of our patients. Thank you very much.
Thank you so much, Madam Dameni, for your input. I will also give this opportunity to Tandasi. I see a hand from her.
Good afternoon, colleagues. And thank you so much, Tim, for such a wonderful presentation. Oh, wow. We learned quite a lot. May I kindly check? I had actually dropped a question on the chat box. What stage is the cancer at, and is the client aware? And was the intention of the chemo discussed with the client? That could be my first question. Secondly, it's a comment. I think here we are dealing with a client who is dealing with a lot. He lost a husband, there's a family disputes, parents are sick, there's just quite a lot going on. But I wanted to check what's the top of the list amongst her issues. Which ones do we really think? Because if we tackle this one, then the client probably could kind of settle down and be able to kind of engage in as far as the chemotherapy issues are concerned. I'll make an example. If she's very much worried about the kids, then I would say let us tackle the issues according to their priority, so that it gives her a chance to kind of assimilate whatever information, because even if we were to ask now, what is it exactly that was discussed during their first meeting with the doctor, maybe she has even forgotten, because top of the list you might find, Guti, with her, it's actually the issue of the kids, issue of school fees, with the boy staying in a house which is falling apart and everything, her fearing the fact that she might die. So right now she's in a situation whereby she feels like she's made to choose between two devils, either choosing chemo, which will kill her, but also she's choosing not to take the chemo at all, which is not making the situation any better. So what I'm trying to say is that I try to prioritize her concerns, and also while dealing with that, try to give her all the information. I'm quite impressed with the plan that you actually presented there, but let us prioritize her concerns.
Thank you so much, Mboni. Did you have a question? Okay.
Thank you so much, colleagues, for your input. Thandazile, you are very right on your assessment. I also did notice that most of her decisions are based on her welfare of the children. So it's like she doesn't put herself first, and she feels like not taking the chemo will prolong her life. So we have to do a bit of explaining there. And then with the cancer staging, unfortunately, she didn't have any documents in hand with her. She only had a green sheet, which didn't state the stage of the cancer. And she also said she doesn't remember, but she was told that it's still at a stage where chemotherapy can be effective. And then with Mage Dlamini's question, about the children. So she has 5 children. The eldest child is 20 years old, and then the others are 11, 17, 6, and 7 years. Yes. So all the 4 are under 18. It's only the one male child who is above 18 years. She's 20, and she also stays at his parental homestead. That is his father's side. So he is the one that reported that the house which he is staying in is falling. And with also the plan to assist her, we are going to try through our social workers office to find other people who can probably assist with the school fees, like those from Young Heroes, Children's Cup, etc. So I am taking note of all your inputs, colleagues. They are very valuable. We will try to employ them when we are working with our client.
Okay, thank you so much. I can see a hand of your mother. I mean, I'm still raising your hand. Is there anything you want to add? Or
Yes, please. There's something I think I needed to add on this one. What I've noticed is that most of our cancer patients are diagnosed. Those who are diagnosed early take their time to consult our traditional healers and all those African helpers or healers. the ones that are diagnosed late, they are the ones that are open to chemo or radiation. Those that are diagnosed early, they go there and then we come back when it's already late. Maybe I'm thinking we are lacking behind on how to teach them how chemo and radiation works. Maybe if you can start there and maybe introduce the chemo, how it works and all the side effects, what to expect, which is better, the chemo or the leaving the disease to progress at its natural level. I think we can get to a point where people who are diagnosed early are the ones that we capture and we give them the chemo or the radiation. Because what I've noticed, as I've said, is that those diagnosed early are the ones that go out to search for those African medication, and then when they are coming back to us, they are at a later stage. They are at the terminal stage, or maybe they've already started the process of dying. Those that are diagnosed very late, most of them, they do take the chemo. Even also some of them do go to the traditional way of consulting Inyangas and whoever else that can be of help. And then some of those the Inyangas and the traditional healers are educated in such a way that they are the ones that refer these people back earlier. And if you are still having that notion of referring the patients to us when they've already failed, when they know that their way of treating them will not help in this situation. I'm just emphasizing on us educating our patients on how chemo and radiation works. Maybe we can even have some teaching aids or videos or some other stuff that can help us educate this patient of ours to take the chemo, because you are saying they said it is still at an early stage, it can be captured or it can be treated through chemo. Thank you very much, ma'am.
Okay, thank you so much for the comment. I will then go back to our team from Mr. Pius. There's something he wants to share with us.
Thank you very much, Tami, for a clear and precise presentation. Maybe one may say that it is wise to first allay any anxiety or misconception the clients have about the chemo, and also let us practice autonomy. Let us at first tell the client all the pros and cons of taking chemo, then allow her to make a decision as to continue or forfeit using the chemo. Thank you.
Thank you so much, Boayo. A comment from, okay, maybe before, okay, I can see your sister. There is a comment from Tandazile. Says thank you so much, team, for the sterling job you all are doing. I so much envy your critical and broad-minded approach to care. Quite inspirational. Keep it up. Thank you so much. Thank you so much, Mshana, for encouragement. We really appreciate it. Then, Sister Mbata, I saw your hand. Let me give this opportunity to your sister.
Thank you so much for the good work that you are doing, Tani and the team, and Ainia Sebenda. But I think we're still lacking on the clinical side concerning the referral and linkage. I don't know how can it be strengthened so that the clients, just like this client, she only came with a green prescription sheet. There's nothing more. We can't even know where was the client referred after she was diagnosed with the cancer. I think we still have to strengthen that part under referral and linkage so that we won't lose our clients and they'll end up, like I've said, that you find that they will go to traditional healers and everywhere. And also, if ever, and also if we can also link our clients early to the psychological care, because being diagnosed with cancer, sometimes you find that they need more time just to talk with the clients, counsel them. It will help them to make better decisions than to attend them when it's too late.
Yeah. Thank you so much for the comments, sister. I'm not sure if I'm leaving anyone behind from the hub team. Mr. Mahla would like to say something before we close the session.
Yes, thank you so much, team, and thank you so much for the advices. Actually, today's case, it's revealing something concerning our system, how we work, where we are, and the management of this patient. And you can tell that the patient was diagnosed, and there's something that didn't happen well on diagnosis. If we could reflect on our previous presentations on palliative care and its onset, and then reflect on the process of breaking bad news, you can tell that the process was not completed, because one of the concepts or the things to be done on breaking the bad news is to develop the goals of care and the plan of care with the patient. And when that one is done, normally you request the patient to bring someone from the family or anyone you will want to be present when that one is designed. So there are possibilities that this patient is carrying a lot of needs that were not cleared up. Sometimes our physicians will need to come close. I'm happy that almost the facilities now, Babane, RFM, we are here, Manzini Hospital, we are still missing Klatikul. We stand up together. It would be nice if we also have the physicians here, so that they can even share their experience on what's so hard also to take the patient through. Sometimes they give the patient more information on the day of breaking the bad news, and the patient will forget. Yet scheduling those frequent visits, developing a plan will help the patient absorb the bad news or the hard stone to be swallowed of this diagnosis. So from this patient, you can tell that he got the news, but they were so hard on her, but then there was no way forward. So she will be moving up and down, searching for help. But then because somebody didn't tell the patient that once you are diagnosed with this is what is in line, this can be done, and then the patient will make a decision. So in the country, we have chemo, that's for free. So we don't know what was said, and breast cancer, they do their best in Babane and Manzini. They do their best to manage these patients. So, and now she will be running away and running closer to leaving her children. So I think we need to work together now in educating these people on how best they can deliver the bad news and linking the patient system. But I say that even writing like breast cancer, you find it's not normal to you as a healthcare worker, just write breast cancer and then think that this healthcare worker will be able to interpret what is happening. But yet breast cancer will know it's stageable, so that everybody who will be in contact with the patient will know. I think those elements are a bit showing up in this case, that we need to strengthen our communication. But in this scenario, I think the issue of allaying the anxieties around the chemo will help also. But then the issue of the children, a priority to her, you can tell that she can even lose health for them. So linking her with the social work and staff will help. But also allaying the anxieties around the chemo, helping the patient understand that what will be the chemo for. But then at this time, it's very difficult if you don't know even who diagnosed the patient, where was diagnosed, so that you can link the person, you can get the information on the staging issues. But I think another thing would be linking the patient with Manzini Hospital. I think Dr. Sinta and Tandazile's team can can mine up the information even in terms of the diagnosing stage to find out any possible interventions and the chemo. I think even if it cannot be a hope to hold on, but saying that, for us to understand what is happening with the breast cancer, I think if you can go to Manzini Hospital, they can explain further if the person is interested to know more. But yeah, I think linking them with Manzini Hospital will do, but then allaying the anxiety first and then linking will do help the patient access the chemo as possible as they can. Because now they will understand what it entails. Yeah. Otherwise, we are losing more of these clients who are scared, who don't know. And this one is the anger issue concerning the COVID-19 vaccination. That it might be because the side effects of breast cancer emanated because of the COVID. So I think she needs more explanation of how come breast cancer came. So I think also the knowledge about how that vaccination works can allay some certain anxieties there, because as long as the patient has anger towards any vaccination, even the chemo, once you say chemo will go through a NICRI, then the patient will say no more me with NICRIs anytime. So I think also understanding that also will help that the patient, there's a lot of anxieties and fears that are around here. So that needs to be treated too. That would be my input.
Thank you so much, Mr. Masago. I can also see a hand from Sister Mata. Sister?
Thank you so much. It's Mr. A. He wants to say something.
Okay, well, welcome you, Mr. A.
Yes, I'm fine. Thank you. I have just joined in. I was just from another meeting, but I was able to get the gist of what this is about. I think also another way of allaying the anxiety would be to use the cancer survivors. Cancer survivors, there are a lot in the country. If we can find a way of engaging them, they can talk to some of these patients and they can explain to them their experiences. That could also help instead of just us using the theory. So if we can also make use of those patients who have survived this cancer and they can explain to these patients, it can also help. Thank you.
Thank you so much, Mr. A. I would like to acknowledge your comments, your input. You have provided this afternoon. It adds value in this project. Thank you so much, colleagues, for that. Next time, do the same. However, there is a feedback link on our chat box. Please click on it and then fill the feedback form so that we can really assess if this project is really helping us or not. So please click that feedback link on our chat box. Yeah, there it is. So our next session on the 21st of June, 2023, same time, same place. And our topic for our next session will be complementary and alternative therapies for pain management in palliative care. Thank you so much, guys, for tuning in. See you next time.
Thank you for joining today. Bye-bye, colleagues. Remember to click that link before exiting.